Hi, good morning and good afternoon, everyone. My name is Jen Lee from the Association of Asian Pacific Community Health Organizations, or AAPCHO. I just want to thank you all for joining us for today's webinar on the National Diabetes Prevention Program, Lessons Learned for Primary Care Associations and Health Centers. Just to provide you a little bit of background, last fall, AAPCHO and our colleagues at the National Nurse-Led Care Consortium, we co-facilitated a national webinar series, a webinar and a four-part learning series, which some of you on the line may have joined us for, really focused on health centers and primary care association stakeholders. Those were a series of HRSA-sponsored training and technical assistance sessions that focused on providing an overview of CDC's evidence-based National Diabetes Prevention Program, or National DPP, as we'll refer to it today, really as a model to improve access to care and prevent type 2 diabetes through health promotion and the implementation of lifestyle change programs. Our intention really is to continue to increase health center awareness of the National DPP program and to highlight the latest efforts in increasing preventative care for at-risk health center patients, which really brings us to today's webinar, which really is a progress to up to date, where we'll have updates from our federal agency partners and also our PCA and health center leaders in this work to share some of their best practices and recent lessons learned on the ground. So I am joined today by my wonderful colleagues, Albert Asen, here at AAPCHO. He's our Associate Director of Training and Technical Assistance, and also our colleague, Emily Kane, who's the Senior Program Manager at the National Nurse-Led Care Consortium. So we will be your joint moderators today. You'll be hearing and seeing us, hopefully in the chat and online. And we are also very excited and appreciative and thankful to introduce our federal agency leaders who will join us today. And we're lucky to have Tracy Branch, who's the U.S. Public Health Service Captain and Senior Advisor for the Strategic Partnerships Division of the Office of Quality Improvement at the Bureau of Primary Health Care at HRSA. And we're also joined by Pat Shea, who's the Senior Advisor of the Program Implementation Branch in the Division of Diabetes Translation at CDC's National Center for Chronic Disease Prevention and Health Promotion. Thank you both for joining us. And more presenters today. We have a packed agenda. We also want to extend our appreciation to our PCA and Health Center co-collaborators for today. We have from the Hawaii Primary Care Association, Brian Wan, who's the Program Manager of Population and Health Systems Improvement, and Jeremy Domingo, who's Program Manager of Health Equity and Research. And then from our colleagues at the Health Promotion Council, welcome Gina Trignani, who's the Director of Training and Capacity Building, and Kimberly Labno, who's the Assistant Director of Training and Capacity Building. So as we get started, as an attendee today, you have a lot of options to participate in our webinar. So you can mute and unmute your audio, virtually raise your hand, and you can also send messages to other colleagues who are joining us today. You can click the mute and unmute button or use your microphone. We also ask that you please maybe keep your microphone on mute during the presentations today. Next to your microphone, there's a little arrow up button on the right side, and that can help you choose specific audio settings for your microphone and your custom speaker system. During the presentation, you may ask questions. We highly encourage you to ask questions. There is a Q&A icon on your Zoom toolbar, and you can type open questions into that field. One of us as moderators will either send a typed response to you or answer your questions live. You can also, as an attendee, upvote if you see a question that resonates for you, and also comment on open questions. So you can click chat to communicate with us, with panelists today and or attendees at any time during the presentation. So you can also chat our team if you have any troubleshooting needs. And if you have any questions during the Q&A time, which we will have today, you can click your raise hand, and as a moderator, we can also open up your audio line to ask a question directly. And afterwards, you just click lower hand to dismiss that function. And then as many of you may be familiar, but to leave the meeting, there'll be a red icon that'll pop up to end attending today. And then we want to make sure you'll be prompted immediately after to complete a short post-webinar survey. So your feedback really makes a difference for us to provide high quality training and technical assistance for future events. So I appreciate you taking those few extra minutes after today's session. Moving on, just so for our agenda today, we're going to be next hearing from her opening remarks from HRSA, and then we'll hear from CDC leadership with Pat on updates on the umbrella demonstration pilot for the national DPP, and then move into, I think, some really great sort of firsthand experiences from the Hawaii Primary Care Association, our partners at Health Promotion Council, and then we'll open up for a general open Q&A at the end before we close. Next up, so we have 3 different learning objectives for today, which I'll remind us of throughout today's presentations, but the first of which really is to review key elements of HRSA's Diabetes Quality Improvement Initiative at health centers and what its relationship is to CDC's National Diabetes Prevention Program. So I'm going to go to the next slide. So we're going to just kick off with a little poll. We did want to know and understand better what your organization's experience might be with the National Diabetes Prevention Program. So we have a little multiple choice. You should see that on your screen now. We'll give just a few seconds for folks to type in responses. But we would love to know if you're currently offering it at your health center, if you're supporting others in offering the national DPP, if you're referring to outside partners such as community organizations, faith-based groups, or other folks hosting the program, or if you're new and the national DPP today will be kind of your first introduction to the program, or if you have any other experience, we'd love to see that. Feel free to chat into the chat box. So we'll give it just a few more seconds. And okay, hopefully that might be enough time. I'll cue Albert. All right. Okay. So it looks like about 18% of you are currently offering it at the health center. Close to 30% are supporting the national DPP, supporting others with the national DPP, which is great to see. And another 14% of you referring to outside partner agency who's hosting the program. And then a third of you also with no experience. So this will be your first time kind of hearing more the nuts and bolts of the program. Let's see. And then I think in the chat, so some folks are planning, see Catherine, planning stages to offer a DPP program in-house. So hopefully, thank you all for answering those questions real quick. Hopefully it gives a little reference point for our presenters today too. So we have a good mix of you on the line. All right. With that, I'm going to actually now transition to Tracy Branch, who's going to give us a little overview of the Diabetes Quality Improvement Initiative.
Hello. Thanks so much, Jen, for that introduction and overview of today's planned activities. So I'd like to thank the National Nurse-Led Care Consortium and the Association of Asian Pacific Island Community Health Organizations for hosting today's webinar, as well as for you, the attendees, in attending and hearing about the updates on federal activities that are supporting the health center program's diabetes prevention efforts. And you can move on to the next slide. If I can move on to my next talking point, sorry. Diabetes continues to be a priority of HRSA's Health Center program. In 2019, 2.6 million people using health center services held a diagnosis of either type 1 or type 2 diabetes. That proved to be a 15% increase over our 2018 data. Of those identified as diabetic, 32% had a hemoglobin A1C of 9% or higher, which, although it sounds high, is an improvement over our 2018 performance, which basically is reinforcing the need for a continued diabetes priority within the health center program. And it's also with that knowledge that only 3.5% of HRSA-funded health centers are currently meeting the Healthy People 2020 goal for uncontrolled diabetes that is leading us to, again, continue those efforts. So next slide. So diabetes is one of the few quality measures that HRSA collects that is stratified by race and ethnicity. And the goal of the Diabetes Quality Improvement Initiative is to reduce the gap that's seen between the group with the best diabetes control, which in this case is Asian populations, and the worst, which are Pacific Islander populations. Since 2018, this gap has decreased by 23% across all of our racial and ethnic minority populations. However, the gap experienced between our best and worst performing minority populations continues and it persists to this day. Next slide. So just to refresh memories, the three overarching goals of the Diabetes Quality Improvement Initiative are to improve diabetes treatment and management across the program, increase diabetes prevention efforts, and the reduction of health disparities seen within diabetes. We accomplish these three goals through collaborations with public and private partners to inform, educate, and mentor our health center staff and patients by addressing health literacy and performance and quality improvement. HRSA and CDC continue to collaborate on diabetes prevention and the increased integration of the National Diabetes Prevention Program into health centers. And in the near future, we'll also be able to identify health centers that have a recognized National Diabetes Prevention Program. Additionally, our primary care associations and national training and technical assistance partners play a vital role in continuing to educate our staff to help introduce best and promising practices that are being identified across the health center program and helping to advance the work that HRSA has deemed a priority within this space. Next slide. So beginning in 2018, health centers, as part of their operational site visits, participated in a performance improvement assessment. The information that was gleaned from those assessments helped us identify trends and needs of the health centers. And by addressing these particular needs, we've sort of tailored and tweaked our ongoing initiative. So looking at the slide, you'll see that some of the trends in areas of need include priority prevention strategies and programming, education for both patients and providers, and strategies for identifying, tracking, and monitoring diabetic patients. Ongoing training and technical assistance that's directed towards HIT and virtual care, as well as partnerships with national organizations such as the American Diabetes Association, American Medical Association, and Project AAPCHO, along with our fellow federal partners such as CDC, are going a long way in helping us address these needs that the health centers consistently are reporting to us. Next slide. So as we know, the one thing about life is that change is inevitable. So in this case, as it pertains to our health center diabetes quality improvement initiative, the plan is ever evolving. So primary and secondary prevention remain key components of our plan going forward. Primary prevention is going to use programs such as the National Diabetes Prevention Program to help reduce the number of pre-diabetics within the health center program that become diabetic. Our secondary prevention efforts are going to work on addressing those 2.6 million health center patients that currently carry a diagnosis of diabetes, with the goals of reducing their risk of the complications of diabetes, such as that cardiovascular and stroke risk that's increased, helping those patients maintain good eye and renal health, and then reducing the risk of lower extremity amputation through education and early intervention modalities. So as you see, although, COVID has sidelined some of our efforts, our initiative continues to be strong, and we're continuing to really promote our initiative over the next 3 years. So again, I want to thank you for joining us today. And again, my thanks to the National Nurse-Led Care Consortium and the Association of Asian and Pacific Islander Community Health Organizations for hosting today's webinar and for taking on such an important topic.
Thank you so much, Tracy. I really appreciate this overview, and I think change is evident. Yeah, and just seeing the evolution, the true evolution of the Quality Improvement Initiative, I think it's exciting, and also I think it just reflects the tremendous amount of work that's happening around diabetes and now prevention, and that context, I think, around the focus on primary and secondary prevention, how that relates to our focus on the national DPP today. So thank you again for your time. I know we're lucky you weren't on deployment for today, so appreciate it.
Yeah, and thank you so much for hosting me and allowing me to provide the overview.
Oh, of course. So with that, I think we're going to transition to Pat Shea from the CDC and get to our second learning objective for today, which really is to provide an overview of the CDC National Diabetes Prevention Program, and particularly the umbrella hub arrangement. So there's been a lot of work and effort going into sustain the program and ensure that it's an effective, sustainable financial model for those of you who are interested in how this all works and will work in the future. So with that, I will turn it over to you, Pat.
Thanks, Jen. I'd also like to start by thanking everyone who's been with us on this journey over the last 10 years or so to help scale and sustain the National Diabetes Prevention Program. We're all sort of pioneers here trying to bring an evidence-based lifestyle change program to the populations that most need it, and just to prevent type 2 diabetes. As the COVID pandemic has made clear, I mean, this has always been critical, and now it's even more critical given the significant comorbidities of COVID for people with diabetes. So I really appreciate all of you, whatever piece of this you've been working on, because no one can do this alone. So just quickly, in terms of national success, I'm pleased to report that we are just short of enrolling 500,000 people in the National Diabetes Prevention Program. We're a little over 495,000, so we should be there soon. And we've currently got 1,750 organizations, and if anything, that hasn't slowed down over the past 6 months. It's actually picked up. We have 256 Medicare suppliers who are now in 1,000 locations, and they've actually had 45 new applications just recently of groups wanting to provide this program. The other thing I just mentioned at a high level is just how flexible and responsive the organizations that are offering this program have been. More than 60% of the in-person organizations really didn't miss a beat. They were able to switch from in-person to virtual delivery. And an even higher number of the Medicare suppliers were actually able to take advantage of the COVID flexibilities and switch to virtual programming. So So the program is still available, and while there are some programs that have had a pause, I would say that in general, we're still moving full steam ahead. So the purpose of today is to talk about a particular project that we started last year, which you'll hear as umbrella hub arrangements, umbrella arrangements, hub arrangements. It sort of goes by different names, but as we were scaling the program, we had concerns about a lot of the smaller community-based organizations being able to actually remain viable entities. A lot of public health programs have historically been funded with grant funding, but at the level we're trying to scale this program, we really needed to find ways to make sure that all of the groups that are providing the lifestyle change program could actually tap into the increasing number of public and private payers that are covering the program. So a year and a half ago in April, we convened a group of very creative thinkers, and we said, let's look at this problem. What do organizations need to be sustainable? And we identified a range of functions, as you can see here. And most of these functions are not things that a lot of traditional community-based organizations were used to doing. So this is a complicated set of requirements, which you'll hear more about as we go into the details. But things like tapping into electronic health records to get referrals, or figuring out how to verify that someone has insurance, or how to learn how to deal with revenue cycle management. I mean, these were new terms even for me as a longtime public health practitioner, because generally we're not working in these venues. So next slide. So what came out of the convening was the umbrella hub arrangement concept. And the idea was to try and find a way to let some of these smaller organizations, or even larger community-based organizations who just didn't have this kind of administrative and billing and legal infrastructure, but to find a way for them to all come together so that they could collectively support that kind of infrastructure. So just at a really high level, the arrangement involves a particular group who agrees to serve as the hub, sort of the main lead organization for this grouping of delivery organizations. And as you'll hear, right now we're looking at two different pathways. One where hubs are actually delivering the program themselves, and another demonstration project where the hub organization is not actually delivering the program, but they're willing to act on behalf of a group of organizations that serve as the deliverers. So in this model, the groups that are actually delivering are called affiliates, or you might hear them called subsidiaries. And then in order for the hub to work, there has to be an administrative and billing platform to bring all the data together and to be able to submit that to the payers through their various claims-based systems. And then in order to make the hub really work optimally, there's other stakeholders, which might be the state health department or other partners in the community or various payers. And so we see this arrangement as having a lot of benefits. Basically, we think will have better impact, that organizations will be able to enroll and deliver the program to a larger number of participants. We've heard that becoming an MDPP supplier is a fairly onerous process for community-based organizations. So by joining together, only the hub has to go through that process and then can act as the billing parties so that all of the other organizations don't have to do claim submission on their own. It helps with CDC recognition. Even though the minimum number of participants required for recognition annually is 5 completers, it's still been hard for some organizations to meet that on a regular basis. And then again, as we talked about, there's all these new business sector concepts about supply and demand and fixed and variable costs, and all of those things just are more affordable and sustainable if groups are joining together and sharing those services. Next slide. After we established this concept, 2020 was a busy year for us. In January, we put out a guidance document for delivery organizations that were willing to serve as hubs. And we had a lot of interest in January and February. We were doing office hours around that and had, you know, about 24 organizations that thought they were ready to become hubs. And then, of course, the pandemic hit. So we've continued to work with about a half dozen of them, but some of them have put their umbrella plans on hold for a little while. But then we also started in February the demonstration project for non-delivery organizations to serve as hubs. And that's, and I'll let the Hawaii Primary Care Association and the Health Promotion Council talk about that, because those were the 2 groups that we initially selected for that demonstration project. So we've been talking about this concept with a lot of groups. As you're going to hear, there's a lot of lessons learned about how best to make these arrangements work. They're simple in concept, but not easy necessarily to operationalize. I guess I would just say here that there is a growing interest here, though, and in particular, a realization that this is an important way to keep the groups that are most closely associated with the at-risk populations, to keep them front and center and find ways to make sure they can continue to serve those critically important populations. I just want to mention that we're about to start a learning collaborative with state health departments. We've got 10 states that are interested in starting umbrella hubs in their states. We've also just started an enrollment project to try and bump up uptake of the Medicare coverage benefit for the National DPP Lifestyle Change Program. And as part of that project, we're also will be looking at ways to maybe group some organizations to have more MDPP umbrella arrangements. And there are also state Medicaid programs that are beginning to look at umbrella hubs. So I think this has been our kickoff year, and we'll see a lot more activity here as we move forward. Next slide. So I think this is just a colorful visual that summarizes what I've just said. Under the umbrella, you can have different affiliates of different size. They, may be small ones that are only enrolling, a few participants a year. Some may be larger, but when they all come together, they can have significant impact. And then, through that arrangement, just afford the technology and systems they need and reach the payers and generate the kinds of reports that are really needed to make this work and scale the program. And next and last slide. So I'm going to segue here to the actual demonstration project sites. As I mentioned in February, we kicked off our Umbrella Hub demonstration with non-delivery organizations, so like primary care associations or academic centers, or there were other groups that serve this function in their community that actually applied for the demonstration. And for year one, we selected the Hawaii Primary Care Association and the Health Promotion Council. And then year two for us actually kicked off in July, and we added a third group, which is Marshall University, which is a group that supports a lot of local diabetes coalitions in Appalachia and across multiple states. So they are joining this demonstration project to try and go first and be the pioneers and hopefully lay out a pathway that will be easy for others to follow. So I'm going to stop there, Jen, and turn it over to the demonstration sites.
Great. Thanks so much, Pat. I really appreciate that overview, and appreciate those of you who are putting questions in the chat or the Q&A box. I think we have some, if our presenters see anything there, thank you, Tracy, for responding to some folks. Really great questions around coverage, and particularly for the uninsured. What does that mean for this program, and how to get more information about the hub? So hopefully, and as you're hearing, we have the few and the brave on the line who are going to share a little bit more about their experience. So I'll go ahead and just turn it over to Jeremy and Brian from Hawaii PCA to share a little bit more about their umbrella model and experience.
Thank you so much, Jen. And thank you to Albert, Emily, and Jen for inviting us to share our experience with the Learning Collaborative. So my name is Jeremy Domingo, and I'm joined with my colleague, Brian Wan, who's really been leading our DPP efforts here at the Hawaii Primary Care Association. On the next slide, please. So we're hoping that we can speak to Learning Objective 3, which is to share some of the lessons learned and how health centers and PCAs can move the needle on diabetes quality improvement and prevention efforts. So to do that, on the next slide, we're hoping that, or we wanted to provide you with an overview of our DPP journey with our health centers here in Hawaii. So we started our journey in diabetes prevention in 2015 with the DP 1422 CDC Prevention Grant. And with this grant, we helped 8 health centers to develop systems to screen, identify, and refer patients who are at risk for diabetes to DPPs that were either on-site or held virtually. And by the end of this grant, which ended in 2018, we had 8 health centers with established DPPs, and 2 of them had achieved full CDC recognition. Following that grant, we continued our partnership with the Department of Health to implement the 1815 grant, which focused on continuing to support the remaining DPPs and developing a payment model for DPP. Through this opportunity, we were able to support 4 health centers with DPPs and 1 additional health center to achieve full CDC recognition. So we had a total of 3 of our health centers with recognition. And Brian again led those efforts, and he'll share more details a little later on. And now, as you've heard from Pat, we've transitioned into this DPP umbrella hub arrangement phase, which involves a partnership with 4 of our health centers, the National Association of Chronic Disease Directors, Levitt Partners, Weld Health, CDC, and CMS. And in this pilot, we are organizing as a network to support our health centers with the administrative tasks of delivering the DPP. So our health centers can really focus on implementation, which is what we know they do best. Currently, 6 of our health centers have established programs, and 4 of them are participating in this pilot. And just recently, we received full recognition as an umbrella hub organization. Also, during these last 5 years, delivery of the program has looked different across each of these phases. We started predominantly with in-person classes. Some health centers did opt to refer to a virtual program, and one health center chose to do a hybrid model where they provided additional in-person support to participants in an online program. Health centers also have maintained in-person delivery, but as we know with COVID-19, they are exploring virtual delivery of DPP and translating their in-person classes into this online platform. Next slide, please. Thank you. As I mentioned earlier, the start of our diabetes prevention efforts began in 2015, where we were awarded the 1422 grant. And the goal of this grant really was to prevent diabetes and heart disease. This was accomplished through a partnership with the Hawaii State Department of Health, our local Public Health Institute, and the University of Hawaii's Office of Public Health Studies, along with our community health center partners. On the next slide, you'll see the 9 participating health centers from 4 islands. 8 of those health centers did implement some form of DPP at their health center. And again, it was either on-site, in-person, or referral to a virtual program. And next slide, please. In terms of our role in DPP implementation, we primarily supported the health centers in a variety of ways. We supported health center staff to attend lifestyle coach trainings with a CDC-approved training entity. We also supplemented these trainings with others that focused on reinforcing group facilitation skills, care coordination, and health coaching. We also provided direct technical assistance to support workflow development within the health centers, ensuring that all those systems were in place before they started their program. We also recognized that many of our health centers needed a lot of support with regular data submission to the CDC. So this involved us working really closely with them to review their data, making sure it met CDC guidance, translating any evaluation reports they might have received from CDC, and then helping them to make the appropriate revisions. We also learned that the health centers needed more localized educational materials that reflect the patients that they served. So we worked collaboratively with our health centers to develop and redesign some materials that they were using with their patients to supplement their DPP programs. We also convened yearly learning collaboratives, which comprised of quarterly in-person sessions and semi-regular webinars to ensure progress and share challenges and lessons learned across the 9 sites. And in the last year of the grant, we broke up into smaller learning teams where our team worked closely with a group of 3 health centers at a time on some DPP quality improvement projects. And these projects were primarily centered around improving recruitment and retention of their DPP participants. And lastly, we worked closely with our State Department of Health and health centers to continually advocate for reimbursement of DPP in Hawaii. And I think I'll pass it on to Brian.
All right, thank you so much, Jeremy. And so after the 1422 grant, HPCA really continued to collaborate with our State Department of Health on the 1815 grant through CDC, which for the most part, as I mentioned, was a continuation of the 1422 activities. And the only difference is that there was an inclusion of cholesterol as a new disease focus. This grant allowed us to start having more discussions around DPP payment in our state through the development of the DPP value-based reimbursement model for Medicaid patients, which is still ongoing for us. So we tried to ensure that there was alignment with existing work. As we know, and which was discussed earlier, there is a national drive from HRSA, and other national agencies to work on diabetes improvement. We try to heavily focus our activities around patient-centered medical home because it really drives overall transformation through a lens that our participating health centers are already familiar with. For example, the work plans that we had asked them to submit for the 1815 grant were pretty much the QI worksheets that they would have submitted for PCMH recognition. And we just asked the health centers to ensure that diabetes and hypertension were one of the selected clinical measures that they had focused on their QI worksheets. This was also done to reduce any sort of burden of duplicating efforts in our health centers and ensuring that there's some coordination in the effort that they do with PCMH and these chronic disease specific grants. And we as an organization at the PCA is working and in transition in doing a lot more of a practice facilitation type of work. And it was really sort of elevated through this grant, through the 1815 grant. Next slide, please. So the next couple slides will be sort of our progress so far on our Umbrella Hub demonstration development and how we are building the blocks for sustainability. And it's really great that we have all our experiences and lessons learned from the 1422 and 1815 and coming full circle to develop our sustainability model and which had been really the goals and the focus of the 1422 and the 1815. So it's kind of great to come full circle and getting reimbursement for it. So next slide, please. And we did want to thank our partners in having us participate in this demonstration project. So many thanks to NACDD, CDC, Levitt Partners, and CMS, as well as World Health, who we will be collaborating with for the DPP program management platform that they have. And we also want to thank our 4 participating health centers in this demonstration, as we are not able to do this work without their support. Next slide, please. So these are our 4 primary project goals for the demonstration. First is sustainability. DPP reimbursement is largely untapped among our health centers in Hawaii. So our initial focus is CMS Medicare DPP reimbursement, but we do hope to expand to other local payers and hopefully towards Medicaid in the future. So DPRP recognition and data will be one of our primary focus as a hub. By being a hub, we will be able to aggregate our data collectively across our health centers. Many of our health centers had difficulty in maintaining recognition due to maybe their size, maybe they were too small, and having the capacity to do more than 2 cohorts in 1 year. And this created a lot of barriers in terms of, okay, will we be able to submit data this year if we can't do a cohort due to lack of personnel, for example. So through this demonstration, we can maintain a full recognition and work towards, collectively working towards maintaining that recognition as a whole. This demonstration also allows us to share infrastructure costs, such as, for example, the WELL platform, where we can have one single master contract instead of individual contracts that will be required of each health center if it was done individually. This also allows some shared administrative costs in terms of the role that we will play as a hub by aggregating the data and ensuring that we submit the reporting and making sure that we pay attention to the billing pieces as well. And as we have our health centers implement their DPPs, we as a hub will closely monitor the DPP data being entered through WELD, as we will also have access to see the patient level data and work collectively in quality improvement activities to ensure that we are meeting our weight loss goals requirements to maintain recognition. Some of our potential training and TA that we've done in the past is sharing the best practices across our different health centers, who may be adding a little bit of flavor to their individual cohorts to help engage their participants in the year-long program. And by having some administrative functions move to the Umbrella Hub level, we hope, as Jeremy mentioned earlier, that the health centers will focus on the delivery of the program and driving that quality. Next slide, please. So we constantly have to remind ourselves to internally, as well as reminding our health centers that this is a demonstration project and there's tremendous amount of opportunities for learning, as Hawaii Primary Care Association has not functioned in this manner before with working towards reimbursement and payment. So we have to remind ourselves that setting high expectations for ourselves, but also making sure that we're grounded to making sure that we achieve those goals. So next slide, please. This is our progress so far. And as you can see, it is a steep climb. We started the initial engagement with NACDD and CDC back in January of 2019. And the application and the awarding of the pilot didn't come into fruition until January of this year. We did have a kickoff that occurred with our health centers and other interested parties in March. But as many of you have experienced this year, many things had been delayed due to COVID-19 and shifting of our focus and priorities towards the pandemic. Because many of the complexities of CMS and DPP, we decided to work with an external partner to help us develop a master contract to have the necessary language that is needed for this demonstration project, as well as the language in a contract that will allow for the flexibility for it to be revised in the future when the demonstration ends. One of the biggest milestones so far was receiving our official DPRP recognition as a hub, and we just received that less than a month ago, so we're very excited for that. We are currently working on our CMS supplier application and working towards executing our contract with WELD. And so we do hope that some of this billing will start early 2021. So that is the goal. And again, we know that this is, the peak is billing, but we know that there may be multiple peaks beyond this one that we are currently climbing, especially when we're trying to ensure that we start developing the sustainability model and plan for the future. And those discussions are concurrently happening as well. Next slide, please. This slide sort of demonstrates or is a diagram of the current model that we have right now with some of the roles and functions. So HPCA is the umbrella hub, and we will maintain many of those administrative functions that we described earlier. Currently, we have our 4 health centers that are part of our hub, and several other interested health centers will join us in the next several months. Each affiliate, we've decided, will be listed as an administrative site for CMS purposes. And we just felt that that definition of administrative site really fit their functions and roles better versus the community site. Data will be entered through the WELD platform that can then be aggregated for recognition purposes to CDC and also for the billing for CMS. HPCA will also be able to review the claims prior to it being officially sent to CMS for reimbursement so we can monitor and ensure data quality. We'll also use that data for quality improvement activities with our affiliates. And lastly, all the reimbursement dollars, we've decided that it will go through HPCA, and we will then pass that through to the health centers that submitted the claims. Next slide, please. Although this demonstration project focuses on DPP reimbursement, we are always trying to think ahead. So when we have built up our infrastructure to bill for Medicare DPP, we hope to explore how we might expand this to other chronic disease prevention and management services areas, such as chronic care management, so CCM, or even the diabetes self-management education, so DSMEs. And with the infrastructure that we've built for the hub, it really sets us up in a path for to become a network, which is very new to our organization and something that we haven't done before. So it's a little exciting for us. Next slide, please. Some of our current challenges so far, as I mentioned, this has been a very steep learning curve for our organization, primarily in trying to learn the CMS requirements and the nuances in their policies. We struggled a lot in defining what our MDPP structure will look like and what our role will be as a non-delivery site. We also had to look at our existing infrastructure and learn what gaps we may have. For example, if we are going to be able to see patient level data through WELD, do we have the current policies that have the language that will protect the data and how we will use that data internally? We also had to learn and understand what type of insurance we would need as an organization to deliver a program like this. And as I mentioned in an earlier slide, we knew we did not have the internal expertise to develop the language for a contract with our health centers that can describe the demonstration, as we had to be able to communicate this effectively with our partners. Our next challenge now is starting to have those conversations with our health centers on developing our sustainability model. So Levitt Partners and NACDD has helped us so far in looking at the potential models that we can drive into, but we need to ensure that we have the right conversations with our health centers. For example, what is the true cost in being an administrative or umbrella, and how can we build that into the sustainability model? So we are in the early stages of those discussions. Next slide, and I'll hand it back to Jeremy.
Thanks, Brian. So we wanted to end today to share some of the lessons that we learned through our experiences in diabetes prevention. So particularly for health centers, first we want to recognize that it's really important to take the time to set up all the systems, from clinic workflows for screening and referrals, tracking of the data, and training all the staff involved in the project. Our health centers were really eager to start the programs, and we really tried our best to make sure that we help them think through these critical steps before jumping into the program. We also encouraged our health centers to leverage health information technology to support their efforts. Some of our health centers embedded the CDC prediabetes screener actually within their EHR systems to facilitate screening and referring patients to their with prediabetes to their DPP classes. Also, our health centers also implemented algorithms from the American Medical Association to help identify patients to recruit for their DPP classes. As with everything, it's important to build into a sustainability plan from the start, as Brian had so graciously mentioned. And with the end of 1422 grad, many of the programmatic staff moved on and transitioned into other positions to address other clinic priorities when the money ran out. So it's really important to make sure that you have a long-term plan for these efforts at your organization. One thing we do know is that health centers are fantastic at partnering with their local community organizations to support their efforts. And our health centers were really savvy in partnering with local farmers to address access to affordable fruits and vegetables. Others partnered with local organizations to find fun ways to incorporate exercise, such as poi pounding, beach cleanups, and group bike rides. On the next slide, we have a couple of lessons learned that we learned as a PCA, and we learned a lot as a PCA, and we've carried a lot of these lessons into our other work. Probably the most important lesson is to be responsible to the health center needs. They often help us come up with some great tools and ideas. For example, we developed a DPP cost calculator to help health centers rethink staffing for their DPP classes and consider an appropriate participant to facilitator ratio to ensure it was actually a sustainable way of delivering the DPP. We also held lifestyle coach refresher trainings where we reviewed, again, basic facilitation skills, highlighted changes to data collection and submission processes, and worked through case studies that presented common challenges that the health centers often reported with their participants. In response to the need for local educational materials, we worked with our communications director to develop the Feel Good Educational Initiative, which focused on making healthy living accessible to all health center patients and their communities. We also found success in supporting our health centers with constant coaching and practice facilitation, as Brian had mentioned earlier. This really helped to strengthen relationships with our health centers, provide that hands-on coaching and technical assistance to help them move along and achieve grant objectives. Many of our health centers also found it valuable to come together to hear how others have been implementing DPP. Often the health centers would adopt some of the practices that others shared to continue improving recruitment and retention of their DPP programs. it's also important to recognize that we couldn't do this alone. As you could tell from all of our slides, we partnered heavily, not only with our health centers, but with other organizations. We've been able to maintain our efforts through a collaborative partnership with our Department of Health and are constantly exploring partnerships with organizations to grow and sustain DPP here in Hawaii. And lastly, it's important to always keep looking ahead and keep looking for those opportunities to partner and sustain all the great work that our health centers are doing. So thank you so much for your time.
Thanks so much, Brian and Jeremy, for the presentation, and really appreciate kind of the honesty around the journey that you guys have been on. And I know it takes a lot of work and collaboration, and I think to remember too, behind the nuts and bolts really is an evidence-based lifestyle change program that works, and we've seen that impact in our community. So, you know, I think appreciate all the time and energy and thoughtfulness that's going into including health center input into building out the model and all the work down the road and up the road ahead. So we're gonna transition and travel from Hawaii out to back here east to Pennsylvania. And I'll hand it over to Gina and Kimberly from Health Promotion Council, who also share a little bit more about their experiences.
Thank you so much. Thank you, Brian and Jeremy, for your presentation. I always learn so much from your work and your sharing, and I can't be remiss in thanking NNCC and AAPCHO and CMS and CDC and HRSA for making all of this possible. Kimberly Labno and I will share more now on the sustainability model of the Umbrella Hub organization, with a special note that each organization is unique and will establish the model accordingly. Health Promotion Council's model is just one example, and it's just 7 months into development. I also want to point out that we'll be skimming a lot of the content that's been provided in these slides to help support you following the presentation, and we welcome you to direct any of your questions to the sponsors of the session, NNCC and AAPCHO. For context on Health Promotion Council's model, we'll provide some background on HPC's history and how we arrived where we are in these partnerships and work, as well as reviewing our network referral hub model and the Umbrella Hub organization financial sustainability and business models. As Pat shared earlier, HPC is a nonprofit organization. We're located in Philadelphia, Pennsylvania. We formed in 1985 as a high blood pressure program. And since then, we've affiliated with Public Health Management Corporation, which is Pennsylvania's Public Health Institute. And then following that, in 2014, we began our focus in the National Diabetes Prevention Program through a subcontract with the Pennsylvania Department of Health, which quickly allowed us to form critical partnerships and expand our subject matter expertise. HPC's mission is carried out by 4 key departments that span chronic disease management and prevention and address critical social determinants of health that impact our most vulnerable and underserved populations that we serve both locally and statewide. In our department, the Training and Capacity Building Department, we work in 3 critical ways: direct services, technical assistance and training, and influencing policy and systems change. We always strive to operate by using evidence-based methods and support best and promising practices, as well as convening partners to leverage and elevate the collective impact of programs such as the National Diabetes Prevention Program. And in this realm, we work to increase the availability of national DPP, as well as awareness among the community members to be served and their clinical providers and social service providers, all which aim to increase referrals to programs, followed by the last pillar, which is coverage, which we need for sustainability for the programs of the DPP provider suppliers. I wanted to just talk a little bit about the timeline and how we have arrived to where we are. But mostly I want to point out the work that we've been doing around developing our hub models, which began as early as 2015 after receiving our funding from the first round of Administration for Community Living funding to deliver chronic disease self-management and education. As you can see highlighted in red throughout the timeline, our work on the network hub models have culminated in our partnership with the National Association of Chronic Disease Directors for piloting the Umbrella Hub organization demonstration model. We have been very fortunate to work with many local, statewide, and national partners over the years, working towards scaling and sustaining the national DPP. So who are and where are the partners? As Hawaii demonstrated with the PCA model, which is very clinically based, and partnering with community-based organizations, as mentioned, we are a community-based organization, while a rather large one. We work to convene a variety of partners from independent CDC recognized programs to healthcare systems and providers. And our goal is to really make it as easy as possible for those with prediabetes and at risk for type 2 to access the national DPP. I'd like to take a moment to engage you in a poll to ask how many attendee organizations have referral prompts established in the electronic health record for National Diabetes Prevention Program patient referrals. And you can answer yes, no, interested in learning more about how to implement. No, we've had challenges in implementing with EHR teams, whether it's cost, IT, lack of buy-in, or technical issues. We'll give you a moment to take that poll. Okay. Okay, so our poll indicates that we have many of you are interested in learning more, so maybe that will be a topic of a future conversation. And it's good to see that many of you do have a prompt, and maybe there are lessons learned that we can collect from all of you. But we look forward, as this is a key part of making sure that it is integrated into the workflow, as Hawaii PCA mentioned. So our DPP Network Hub, this is the front-loaded side of the work in the national DPP. Prior to becoming an Umbrella Hub organization, as I mentioned, we've been working on addressing the issues around recruitment, referral, and enrollment, addressing those barriers that are associated with getting people into the national DPP and other chronic disease prevention and management programs. So we established our network hub based on lessons learned from the Administration for Community Living work with technical assistance from the National Council on Aging. And the aim is to allow one point of referral into programs where we partner with, the aim is that we partner with these programs to allow clinical providers and clients themselves to refer themselves into the programs, and then we assist in navigating to find a program that is suitable for that person, and then closing the loop back to making sure that the clinical provider or behavioral health provider that has referred that person receives an outcome of the referral. So as you can see, the red star indicates the starting point. The referral comes into HPC by means of secure fax, email, or direct secure messaging, as well as a telephone. And then HPC works with the individuals to identify the program that works best for them. There is secure delivery of the enrollment list to the DPP provider suppliers. And then, as I mentioned, that the outcome of the referral is reported back. And then we also work with the DPP provider suppliers to make sure that they're also closing that referral loop to have the benefit come back to the clinical providers as documentation. So now Kimberly Labno, our Assistant Director of Training and Capacity Building at Health Promotion Council, will talk more about HPC's Umbrella Hub arrangement and the sustainability model focused on data collection, claims processing, and payment remittances. Thank you.
Thank you, Gina. Next slide, please. This slide graphically depicts the nature of our Umbrella Hub arrangement, with some of the content having already been described by Pat Shea from CDC and our colleagues from Hawaii. HPC has designed its version of the hub model to include a diversity of DPP suppliers in the role of affiliates with related duties as shown in the yellow rectangle at the bottom of the slide. We leverage our existing legal and financial services as a subsidiary of Public Health Management Corporation to contract and assume the role of fiscal agent. HPC has relationships with payers as shown in the bubble in the right quadrant of the slide that will fuel the hub's impact in sustaining DPP. As the umbrella hub organization, HPC has the responsibility to maintain CDC's diabetes prevention recognition program status, sustain compliance with CMS and additional payers, manage contracts and quality assurance with our affiliates, and act as a fiscal agent for collecting and distributing claims reimbursement. This slide has a significant amount of content and in essence is the stepwise process or roadmap for the HPC hub arrangement. The process begins with recruitment of participants by the affiliates, and the process completes with the reimbursement of payment to the affiliates for their service. I'll briefly describe the steps of this slide now. HPC has 3 wonderful and committed affiliates in our current hub roster: a health system, a government agency focused on older adults, and a community-based organization primarily serving the Latino community across Pennsylvania. The responsibility of the affiliates are consistent with their existing roles as DPP suppliers, with 2 noteworthy modifications or new activities. First, affiliates implement an intake process for participants that include collection of insurance information and consent to bill on their behalf. And secondly, affiliates commit to track and manage their data in the proprietary Weld Health software. And as we will see in the next step, Weld Health, as described previously, is the data management and billing vendor for the pilot. The next step, step 2 of the process, is on data entry, monitoring, and the reporting side of the software platform functionality in an area known as the Weld portion of the platform. Weld is the portion of the platform that tracks data and releases and reports information to CDC's DPRP program. Step 3, as shown in this process, is a placeholder for integrating an optional revenue cycle management feature offered by Weld Health and adopted by HPC for its version of the hub model. And I'll touch on the function of the RCM a little later on. Moving on to step 4, this is where the billing side of the software platform, known as Ability, enters into the roadmap. The Ability portion of the platform creates a claims object and submits claims to payers. Prior to the release of data to CDC or submission of claims to payers, affiliates with support from Health Promotion Council as the umbrella hub organization are responsible for the quality assurance and that the information is correct and accurate. Once Ability submits the claim to the payer, as shown in step 5, the payer will process claims and remit payment to HPC or block claims process according to relevant statuses such as denied or resubmit. If a claim is not processed for whatever reason, it recirculates to the affiliates for correction and subsequent resubmission. HPC is responsible for accounting of claim submission, process status, and receipt of payment. And we elected to use the revenue cycle management feature offered by Weld Health as a helpful tool for supporting claims management oversight in terms of automating claims accounting and communicating updates and statuses with and across the affiliates in the hub organization. The final step in the hub process is where HPC will disperse the difference of the claims reimbursement payment and the operating costs of the hub to the affiliate on a regularly defined schedule. The goal of the CDC demonstration project, as has already been surfaced, is to create a financially sustainable model for the provision of DPP. HPC has outlined assumptions that we're using to support the first iteration of our financial model. However, a cornerstone assumption is the MDPP reimbursement fee schedule, which is shown here for the first year of Medicare DPP programming. The key point of this slide is that the maximum reimbursement for a participant meeting reimbursement requirements for the attendance in the core period, attendance combined with weight loss performance in the core maintenance period, and a 5% weight loss performance quote-unquote bonus payment is $466. As such, Medicare reimbursement is designed to cover costs of the instruction of the curriculum, with ancillary activities such as recruitment and retention to be paid for through other means. HPC made assumptions to begin the financial modeling that can be categorized as operating costs for the hub, operating costs for the DPP suppliers to conduct their programming, and the expenses associated with the Weld Health technology software. In addition, we recognize that many of the factors that strongly indicate the fiscal solvency of the hub model originate with the DPP supplier. For example, factors including the number of participants, their related insurance coverage within each cohort, and the retention and weight loss performance of the participants are all important factors. The quantity of cohorts that an affiliate has the capacity to offer annually is also considered a key indicator of successful DPP sustainability. Many would agree that the Medicare coverage of DPP set an important precedent for individual states to adopt Medicaid coverage of the program. This slide depicts a summary of cost and reimbursement values from the National Medicaid Coverage Pilot Project. Complete details of the pilot project are available on the National Coverage Toolkit website, located at the highlighted URL at the bottom of the slide. As Health Promotion Council moves forward with the second iteration of our financial model, we have identified information that we will need to collect to further refine the model. These elements include 1, the number of affiliates and related capacity needed to support the hub's administrative as well as the DPP supplier delivery costs. 2, to analyze the cost study currently underway to determine the hub's operational budget. 3, evaluating where efficiencies might exist for reducing program delivery costs in areas such as their staffing model, use of technology, and so on. 4, finding complementary financial support to offset costs of social determinants of health resources that show promise for facilitating increased enrollment. The hub's responses to fulfilling these gaps of information are among our objectives for the Year 2 pilot activities. That said, we have come a long way in the first phase of our hub development with several accomplishments that I will highlight here. Together with our affiliates, we've completed formal agreements that now establish the hub and have, as part of that process, designed and committed to a project charter that outlines the core purpose of achieving a financially sustainable DPP delivery model. HPC has completed contracting with Weld Health, the data management and billing vendor for the project, with documented lessons learned along the way that we think will benefit other organizations that choose to pursue the hub organization as a pathway for reimbursement. As previously described in some detail, HPC has vetted the first iteration of the payment model and identified additional factors needed to refine and strengthen this product. To enable the achievement of our MDPP supplier enrollment status, HPC has successfully enrolled the hub organization in the CDC's Diabetes Prevention Recognition Program and received full recognition status. We are currently preparing to submit the hub's application to CMS for MDPP supplier enrollment status to draw down Medicare reimbursement. And in parallel, HPC is in the process of enrolling in the Pennsylvania Medicaid Assistance Program as a DPP vendor, which is an essential step to contract with Medicaid Managed Care Organization for submitting claims, as DPP coverage is mandated by Pennsylvania's Department of Human Services. Finally, HPC would like to acknowledge the award for Year 2 funding by the National Association of Chronic Disease Directors so that we may continue to fully invest in the development of the hub model. Only together can we prevent type 2 diabetes. Thank you.
Thank you so much, Kimberly and Gina. It's impressive to see, I think just in 7 months or a little bit more, how much has been accomplished and already what you're on your way to doing, and appreciate some of the conversation and exchange and chat too for others who've been able to build off of national DPP grants and infrastructure to something more sustainable and towards more of a hub-like functionality. So much more to learn here. I think in our last 15 minutes, still want to kind of provide you all with a little bit of a recap. I think since we have a mixture of folks on the line who are new to the national DPP and those who are also PCAs functioning to already spread and promote and refer to national DPP affiliate sites. But we did want to recap some of our lessons learned from the 2019 National DPP Learning Collaborative with PCAs and health centers to see how they are helping to move the needle on diabetes quality improvement and prevention efforts. So I'm going to pass it over to Albert for that summary.
Thanks, Jen. And I just want to acknowledge that, yeah, we have plenty of questions that we're going to try to answer with Hawaii PCA and HPC and CBC, HRSA on the line. So just quickly for those other PCAs who aren't umbrella arrangement organizations, there was a lot of participation in the 2019 National DPP Learning Collaborative that was hosted by NNCC and AAPCHO about a year ago. And we really walked through kind of 4 different modules, which is on your screen here, where we kind of provided an overview of what the National DPP was for PCAs and health centers in the room, talked about models for success and examining the role of PCAs and health centers. And this is where we had the American Medical Association, Hawaii PCA, kind of present their lessons learned, acknowledging that they were kind of building and flying the ship at the same time. And then the third module, we really talked about the partnership piece that our colleagues here have mentioned over and over again. It really does take a village to move the needle on diabetes prevention. And so we provided, again, some examples from the YMCA based in Harrisburg, Pennsylvania, and also HPC presented during module 3 to really talk about the memorandum of understanding that was developed between kind of CBOs and partners in Pennsylvania. And then lastly, we had CMS close out our module on kind of the reimbursement 101 to really talk about sustainability and funding. And so we have a lot of resources that we can share. And perhaps we might do an assessment to see if PCAs and health centers are interested in doing another iteration of a learning collaborative through our organizations, seeing that we want to do continuous learning across our state, local, and national organizations. Just to give a recap again, we really hosted this learning collaborative across different states. 10 states were represented from west to east. So we were, again, happy to have a diverse breadth of organizations in the room. And that included 11 different health centers and 9 different primary care associations. And again, really thankful that a lot of the engagement was maintained across the 4 different sessions. And I do want to acknowledge that Oregon PCA, who wasn't able to join us today, was really active in trying to figure out what their role was to provide national DPP education for their health centers in Oregon State. So I want to give a shout out to Kira Templeton. She is the Quality Improvement Manager at the Oregon PCA. She provided just kind of this historical context from their state perspective in terms of really building kind of data strategy and transparency across their CHCs in Oregon in 2014. And then moving forward to 2017, they started developing partnerships with some local organizations, one being Co-Imagine Health, which really provided some diabetes self-management and national DPP TTA to their Oregon organizations, and FQHCs were included in that. And then within the PCA model, just like HPCA today, really providing a lot of quality improvement and coaching and learning collaboratives for their health centers, seeing that everyone's moving at different speeds and that you might need to just kind of recalibrate and reset. And every time a new organization comes in and wanting to know more about diabetes prevention, including national DPP initiatives. And so Oregon participated last fall with us and really learned a lot from HPC and YMCA in terms of developing memorandum memorandums of understanding between partners in the community. And now they're moving in this kind of upstream focus at the PCA with their health centers and using the HRSA Diabetes QI initiative that Tracy mentioned earlier to really guide their next 3 years of work at the PCA and CHE levels. And so just to recap, again, we want to acknowledge that HRSA has a diabetes initiative to help reduce new diagnoses of diabetes by 5%. And so Oregon PCA is hoping to do a environmental scan and readiness assessment with their FQHCs to see what their involvement is in the national DPP. And so that'll inform their next few years of work. And perhaps one day they'll become an umbrella arrangement as well and really grow the stake in terms of focusing on prevention rather than control for diabetes. So just wanted to share that and hope that is helpful for the PCAs in the room. And I'll pass it on to Emily to close it out with some Q&A.
Wonderful. Thank you, everyone. And just a huge thank you to all of our speakers for taking the time out of their day to present this information to us. It's incredibly helpful. And to all of you who are continuing to express interest in these initiatives and engaging in the chat, we really appreciate it. So you can go to the next slide, Albert. Just wanted to highlight some resources that are available to you all, as well as the resources that have been shared by some of our speakers in the chat. We'll make sure that you have access to those. There's a slide deck available for you to download of today's presentation, but we'll also be sending that out via email after the webinar tomorrow, I believe. So you'll have these resources for you to reference later. Also just wanted to shout out a publication that is at HRSA as we speak and will be available soon. It's some of the key elements for successful implementation of the national DPP that we worked on by interviewing several health centers, including some in Hawaii. So with the help of Hawaii PCA, and HPC was a great partner on this case study. So we're really excited to be sending this out to all of you in the very near future. And so finally, I wanted to turn over to our Q&A. We have a lot of great questions, some of which are in the chat. If you would like to have your question elevated to Q&A, please go ahead and just copy and paste your question from the chat into the Q&A pod so that we can keep track of everything and make sure that we're capturing everybody's question. I wanted to start with the question from Stephanie Spencer. I know Tracy had provided an answer there, but wanted to raise this to all of the speakers. Stephanie asked, is there a reimbursement model that could go directly to CBOs or CHCs that serve uninsurable patients rather than reimbursing for specific services to individual patients and clients? So I think this might be an answer for some of our umbrella hubs on the call today, including HPC and potentially our CDC colleagues as well. Does anyone like to answer Stephanie's question?
Emily, will you please repeat Stephanie's question?
Sure. Sorry about that, Gina. Is there a reimbursement model that could go directly to CBOs or CHCs that serve uninsurable patients rather than reimbursing for specific services to individual patients or clients?
I can certainly share from Pennsylvania's perspective. I know there's been many organizations in the chat mentioning CDC 1815 funding. So there are some funding sources that are at the state level through CDC that still support capacity building for diabetes prevention. So I would definitely reach out to your state Department of Health and see if there are any funds or if they're working with individuals. So in Pennsylvania, our state health department filters the funding through what's called regional primary contractors. HPC is one for the southeastern Pennsylvania region. So that would be one. I would still reach out to the payers and see if they have a community arm that can pay for this while reimbursement is worked on.
Great, thank you, Gina. And Stephanie, your PCA, your Primary Care Association, may or may not be able to provide you with additional resources about that in terms of accessing payers, things like that. Anyone else have any further information for Stephanie? Great. Let's move on to Carolyn's question. Carolyn asks, are FQHCs that are providing national DPP accepting referrals from the community that may not already be an established patient? That's a great question, Carolyn. How is this being handled for documentation and billing to CMS? So anyone can answer that. I think Hawaii PCA potentially could answer that, and CMS, Pat, if you'd like to.
I mean, I can jump in on that to take an initial stab. I think for some of our health centers, because it wasn't they haven't been billing in the past. That was one way that they were taking in community referrals, because it wasn't really a billing thing yet. It was grant funded, so they were able to.
Looks like we might have lost you, Brian. Maybe on mute again.
Oh, hello, sorry. So I think one of the conversations I had with the health center on Monday, they did ask that question. And I think the one thing that we did ask was to kind of work internally with their team, just so that they are able to make sure that the community referrals are from partners that they have some sort of partnership with, because we wanted to avoid any sort of, saying that they're trying to take our patients, right? We wanted to avoid that. So just making sure there's those types of agreements in place. But in terms of like the details, we haven't quite figured it out, or we haven't gone to that detailed conversation with the health centers yet. But we do know that it's something that we need to have in terms of working towards, because there is a lot of gaps in our communities in terms of the availability of DPP. Right. So making sure that those gaps are met, and that we work with other community organizations that are providing DPP, so there aren't any overlaps or competitions. For example, the Y in Hawaii, where we have close relationships with them, because it's sort of the relationships that were built by our Department of Health and bringing the partners together.
Great, thank you, Brian. Anyone else have anything to add to that?
This is Gina from Health Promotion Council. I can share that Public Health Management Corporation is having discussions with us around opening it up to the community and navigating that exact question that Brian brought up around competing patients, and making sure that external providers are not concerned that their patients are going to be taken.
Mm-hmm. Thanks. I think Carolyn's question too, in addition to that, also speaks to, is it possible for the national DPP programs to count and, account for those clients if they aren't necessarily patients? And so that's really a question. And Pat, if Pat Shea, if you're still on, I'd love to get your perspective on that, how to kind of maybe navigate that. And I know it might be something that's still in the works in terms of being official.
So I'm not exactly sure how to answer the question. I mean, for DPRP recognition, I mean, once a program is recognized, they can serve anyone that's eligible. And then I expect this becomes a question more for the payers.
Right.
I mean, so to become a Medicare supplier, you just need recognition, but most Medicare, if they're a provider for another type of service, they still have to be approved as an MDPP supplier and bill under that number. So this feels to me like it's probably more of a CMS question,
right.
But if a federally qualified health center is approved also as an MDPP supplier, I don't know why they couldn't serve anyone and bill anyone that's eligible for Medicare under their Medicare supplier number. Mm-hmm. But that's a little out of, CDC's ballpark in terms of once the money starts to flow.
Right. Yeah. And I think to your point, Pat, Medicare maybe is a little more straightforward than Medicaid, which I think a lot of the community health centers are probably also kind navigating with their patients. And so that is a great question for CMS, who we have had participate on some of these activities, as Albert said, so we could definitely try to get some more additional clarification around that.
And Emily,
Yeah, I think as far as Medicaid, that is clearly will be different depending upon the state, because some states have made a decision to follow what CMS did for Medicare and create a new provider class. That's, for example, as Gina mentioned, what Pennsylvania is doing. You have to actually register as a Medicaid supplier, but that's not true in all states that are that have Medicaid coverage for the national DPP. They're all doing it a little bit differently. So
exactly. And Tracy, you were going to add something as well?
Yeah, the only thing I was going to add is that, and I think from the perspective of reporting, for instance, like UDS, you know, that patient distinction can sometimes also become important, because I know that's a question that comes up frequently in terms of, you know, what defines a patient of the health center for tracking and reporting purposes. So I guess that would be the only other area where, beyond just reimbursement, where that could potentially come up.
Right. Thank you so much. All right, I know we're at time. I just wanted to quickly address Kay's question as we go on to the next slide, which is, it sounds like there are only 3 umbrella hubs. Please clarify. Confused about whether this is the end of or an ongoing pilot. So that's a great question. I think we can just quickly answer that, Pat. There's 3 umbrella hubs to date. Is that correct?
yeah, we have 3 non-delivery sites in the demonstration project. We have another half a dozen that are actual delivery organizations. There's no cap on the delivery organization hubs, but we are providing financial support to these 3 groups in the demonstration right now.
Right. Thank you for clarifying that, Pat. And I believe that the intention is to continue increasing the number of hubs. Is that right?
Yes, although there won't necessarily be financial support from CDC to do that. There may be some support from those 10 states that would be using, as Gina mentioned, their 1815 funds to help establish hubs within the state. But at this point, CDC doesn't have plans to expand the demonstration beyond the 3 sites that are currently in.
Great. Thank you so much for clarifying that. So I know we have a couple of additional questions. We will certainly answer them offline and make sure that our speakers receive those questions and that we answer them for you. I wanted to bring your attention to a link in the chat for the CME CNE credits for today. And then also remind you that once you leave this session, you will be prompted to complete a very brief evaluation for this webinar. And we really appreciate your feedback. It helps us plan additional training activities and, you know, just optimize what we're offering and providing for all of you. So I just want to again thank all of our really wonderful speakers for their time and expertise. I want to thank all of you for joining us today, and we hope to see you again at another training opportunity in the near future. So thank you, everyone. Have a great rest of your day.